Latakia City Expats Club is a non-profit social organisation and our speakers are volunteers. The club as such assumes no responsibility or liability for the professional reputation of or the quality of services provided by the speaker today.
This is hence we are cancelling next week. So the most important thing I say, switch your phones off or to vibrate so you can pay full attention to the speaker. It's Doc Martin. Your life could depend on it, all right? Pay attention to the man, okay? I know some of you have come here specifically because you love Doc Martin and his honesty and what he shares. And, by the way, I wrote an article going back that was published in a national, it was Australian Penthouse, and it was called it was called How to Translate Doctors' Bullshit. Okay, so Doc Martin has kindly agreed to facilitate this. He's going to do later on. We're going to do an excerpt from it. He's going to read the doctor's part, and I'll translate the doctor's bullshit for you. All right, so handing over to one of our most popular and revered speaker, the Reverend Doc Martin.
That was nice. I'll come back. Now, we have to decide whether this is the best way of hearing me. People say there's an echo and they don't like it. Or would you like me to use a microphone? You okay? Everything okay? Stay as we are? Is that okay? All right. Okay. Question and answer. So this is an informal thing. I'm going to go through a few patients just for your interest. And I want you to think like a doctor. So I'm going to try and help you think like a doctor. And then we'll talk about screening, health screening. And then we'll talk about cholesterol and strokes and heart attacks, and then I'll sit down and you can ask me anything you want. Does that sound okay? But the idea is that I would like you to try and think like a medic. That's what this is all about. Okay. Here it is. It's working. Don't I just point it to the screen? Yeah. So I want to take it up. There. Okay. Big Ron. No, he's not. No. 3 days ago. They wouldn't let him stay any longer. So Big Ron fell over. I was actually pushed over off his bike. And he broke his hip. Now this is medical nomenclature. So this is his break here. Now medical nomenclature, the way doctors talk to each other is very, very specific. Because when you describe something, the doctor knows in his mind and can see in his eye what you're talking about. Okay, so it's not a flimsy language, it's very, very specific. So this chap has broken his right hip through the trochanteric line, see it there? And you've got shortening of the leg here, see it's lifted up, should be down like that. And you've got external rotation. Can you see that? So this is a hip fracture through the intertrochanteric line. That's the greater trochanter. That's the greater trochanter. That's the lesser trochanter. And it's through this line here. Common place to break it. Ron had his operation. Good operation. See, it's pulled it back in line and things. See that? Any questions? No? So, this happens a lot. When Ron was in hospital, there was another chap who had broken his hip in exactly the same manner.
Sorry, doctor. We've still got issues with this mic. The breath is too strong. Sorry.
Is that better? Yeah. They don't like my heavy breathing. Pathetic. Okay, so we've talked a lot about whether or not you should stop at an accident, especially with ties, and the big answer is no, because it's just not worth it. But Farangs are completely different. So you've got an accident, there's somebody lying on the road, and as I was saying, when Ron was in, there was another chap who'd done exactly the same thing. What do you do? Well, as a doctor, what would you do? You see somebody lying on the floor, what would you do? First thing you think of as a medic. Oh, well, there's normally people standing around in any case, but as a medic, what would you do? First thing, ABC. Airway, breathing, circulation. Okay? Easy. So Ron was lying there like this, and his ABC was okay. What happens in this fracture is that you get shortening of the leg and external rotation like that. So the patient's lying on the ground with his leg short, rotated like that. So if you want to be really clever, you go and say, look, this chap's ABC is okay, and by the way, he has a hip fracture. Nobody will know why you know that, except you've seen the leg is short and twisted out. Dead easy. And then you can walk away feeling really clever. But it's good because you can tell just by looking what's wrong with the patient. Don't need an X-ray. All right, so Ron's out now, back at home. So frontotemporal dementia. About 300,000 years ago, we morphed into Homo sapiens. We became hunter-gatherers. What's happening? I have to tell you about Big Ron, because he had his operation. He was supposed to be walking the next day. 4 days later, he hadn't been out of bed. So I phoned his surgeon and I said, look, this is bad, he could get a blood clot and things. I said, you've got to get him out. So the nurses got him out like 15 minutes after I'd been on the phone to the doctor. And Ron got in the wheelchair, and they sat him by the window with his leg up like this. Half an hour later, they put him back to bed, but they couldn't get him out the wheelchair because he's so big. Two nurses end up in straitjackets with their bad backs and things. No, I'm exaggerating now. Anyway, so this is not an uncommon injury. Because older Frangs that come over here walk on uneven streets. I mean, they're very dangerous, the streets over here, so beware. Anyway, 300,000 years ago, we morphed into Homo sapiens, becoming hunter-gatherers. Our large neocortex, the forebrain, or the youngest part of our brain, that brain was used principally for two things. One was self-defense, because when we were swinging from tree to tree and living in caves, we had to defend our territory. But when you become hunter-gatherers, you have to you branch out and you become more social. So the forebrain was psychopathic in those days originally. So the original Homo sapien was psychopathic or antisocial personality, as DSM-5 call it. And the second thing it did was the big brain was important for for photographic memory. So when they moved, they knew how to get home again. So an eidetic memory, photographic memory. But over the years, as we became more social, there was a development of the frontotemporal axis. Frontotemporal axis goes from the front, obviously, here, to the temporal lobe, and back into the deep part of the brain, and that connected the front psychopathic element to a control factor, which was this frontotemporal lobe, frontotemporal line, and it goes into the amygdala and places like that where emotion's stored and things. So as we developed, we became controlled by emotion and feeling and things like that, as opposed to just aggression and survival. So, anybody here had any psychopathic tendencies? Hands up. Hands up. Hands up, everybody. Hands up. No, hands up, everybody. Psst. Okay. It's true. We're all psychopaths. When we're born, we're psychopaths. Okay? Because this frontotemporal line, which controls your emotion and stops you being a psychopath, doesn't develop until you're about 4 or 5 years old. So we're all being psychopaths, and we all have the potential to be psychopaths. Now, frontotemporal dementia, I had a patient with this about 15 years ago, lovely chap, gentle, funny, kind, wonderful marriage, and he got this dementia, and progressively he became aggressive, nasty, volatile, out of control, and his poor wife just didn't know how to cope. Well, she couldn't, and eventually wasn't sectioned, but he was put in a psychiatric hospital. Anyway, very sad. And of course, so this is, I'll just show on here. This is the frontal lobe going deterioration, frontotemporal dementia, and the frontotemporal fibers come down here and then into the deep parts of the brain. And you can see this is the dementia, so all the white tissue there has disappeared. This is a 60-year-old female. And aphasia is common. Yeah, and that's where he is now. Look at his look how he was, and look at his eyes. See that? There's nothing there. He can't speak now. This was a man who was a humorous, intelligent, voracious reader, and now he's got nothing. Okay. Any questions? No? So how important is medical history in establishing a diagnosis? How many diagnoses can be made in what percentage of patients just on history alone? Any idea? 82. 82% of diagnoses can be made on history alone. All right, so here's some. I run a service where people. I do telephone consultations, and I've got a couple just recent ones, which you might find interesting. So, Rob, 52-year-old Rob. Let me see what the next slide is. Yeah. Okay, so Rob, 52-year-old, past medical history of asthma, broken bones, pneumothorax, etc. Family history of heart attack, type 2 diabetes, and sister had malignant melanoma. He smokes with alcohol only, and he was on baclofen, sucralfate, and omeprazole because he had reflux esophagitis. But he was phoning me because it got worse. Now, obviously, the test I did was for Helicobacter pylori. You know what that is? Yeah. Sorry? Yeah. Well, it's Campylobacter is actually the original name, Campylobacter pylori. But it's very dangerous, extremely dangerous. And it's a class 1 Campylobacter. And 89% of all gastric cancers are caused by this bug. 89%. Sorry? And out of all the cancers worldwide, Campylobacter causes 5.5% of them. That's how dangerous it is. So I did his test and it was negative, which was nice. So he still had reflux, and he still had indigestion. So if it's not Helicobacter pylori, which causes reflux and things, we've got the next, if it's not that, the next thing in line is Barrett's esophagus. Now Barrett's esophagus is a pre-malignant condition, and it's caused by recurrent reflux. Now this is the lower end. This is the lower end of the esophagus, and what happens is the acid refluxes from the stomach goes up into the gullet and damages the cells. So the cells protect themselves by changing from stratified squamous epithelium to columnar epithelium, which is cells from the stomach. Plus you get goblet cells, which we don't see until you get to the small bowel. So this is a protective transformation here to stop cancer. But if you let it go, because it's pre-malignant, it will turn into cancer. Very important. So he needs an endoscopy. I'll come back to him in a minute. His wife, Anne, 46-year-old, she had appendicectomy, past medicals, appendicectomy, hysterectomy with her first child when she bled out, and they removed her pelvis, her pelvic organs. They took her uterus out, and ovaries and things, because she needed bled to death. So she had an appendicectomy and the pelvis organs removed. Family history of obesity, hypertension, renal failure. Sister had migraines. So she wasn't a smoker and didn't drink alcohol. Now she was on Celebrex, 200 milligrams, the pain, twice a day. Now 200 milligrams twice a day is a massive dose for a Thai who's 45 kilos. It's just huge. And in the West we don't allow doses higher than 200 milligrams unless they've had an ECG, because COX-2 inhibitors can produce arrhythmias and things. But she didn't have anything like that. She was just on a massive dose. She was on Lyrica and Tramadol for her pain. And she complained, why did she phone me? Or why did I talk to her? She had numb toes and legs, and itchy palms, epigastric pain, right iliac fossa pain. Okay, so what's wrong with this lady? Why would she have neuropathy type symptoms? Any idea? No, of course you don't. So I did. She, as far as I was concerned, she had vitamin B12 deficiency, because that vitamin B12 deficiency causes neurological problems. It causes peripheral neurological problems, and it produces paresthesia in the feet and things. So this was her blood test. Now I asked for a B12, but she went to a public hospital and they refused to do it because 800 baht, and it takes 2 months for the public system to do a vitamin B12. So what do you think of this? Was anything wrong? Sorry, what was that? Very good. Players, yeah. Anything else? Sorry? Yeah, plays. We don't. That's okay. Don't worry about that for the moment. But this is vitamin B12 deficient causes megaloblastic anemia. Okay. I was quite proud of this because I made the diagnosis and this confirmed it. So she has red blood cells are low. You can see that. Hemoglobin's low. Yeah, 12.9. So an MCV, mean corpuscular volume, is 32.6, and it should be less than 30, between 27 and 32. These things are all significant. mean corpuscular hemoglobin concentration was low. So she had a megaloblastic anemia. So her B12 deficiency was interfering with her red blood cells. Why is that? Well, and this is why it's important, by the way, when you get blood tests done, not to just look at these and if this is in the right area, just ignore it. Because all these things mean something. All these results, they're there for a reason. Oh, that's wrong. Oh, I lost it. Oh. I've lost a slide. Oh, did you? Oh, I had no Wi-Fi for the past few days. Well, it didn't, okay. All right, so, yes. Well, one of them. I'll come into that later. I'll come into that. I'll cover that later. But good point. Very good point. But I was looking. Well, I diagnosed. I told her, you've got megaloblastic anemia. You've got B12 deficiency. How do you know? Do the blood test. So the answer to your question is, if you've got iron deficiency anemia, then the hemoglobin's low. Oh, the hemoglobin's low, but so are all the parameters. The mean corpuscular hemoglobin's low, not high, and that's the clinching thing. You don't get a high MCV in iron deficiency is low. It'd be on the low scale. That's how you can tell the difference. That's why you should always read. That's why I'm trying to teach you guys. Read your results. Don't just think they're all in the normal range, so everything's okay. It's not like that. It's not that simple. Okay, so the clues in this girl. Why did I think she had a megaloblastic anemia? Because she had a pelvis operation. Firstly, it was appendicectomy, and then she had a pelvic clearance. Now, the absorption of B12 involves ingestion, goes into the stomach, where parietal cells secrete intrinsic factor. The B12 binds the intrinsic factor, and it goes all the way through the small bowel to the terminal ileum, where the B12 is absorbed. Now, if any part of that system is broken, you can't absorb the B12 at all. Doesn't matter how much you take. And that's what happened to her. I think her terminal ileum had been cut and removed when they removed her uterus. And it was also damaged, it would have been damaged, because she had an appendicectomy when she was younger. And it wasn't done laparoscopically. Apparently she got a big scar here. So, what do we do? Well, she needs B12, but we can't give it orally because by definition, yeah. So we have to give it intramuscularly. Now, if somebody has a stomach removed, for example, then they have to have it for the rest of their life every month. Same with this girl. She's already developed neuropathy. And as she develops the neuropathy, it gets worse, it becomes permanent. And there's something called, not very common, but it's called subacute combined degeneration of the spinal cord, which kills the posterior aspects of the spinal cord and the lateral aspects of the spinal cord, so they lose proprioception, balance from the back part, and sensation in the feet. And the other one is a motor problem, so they become paretic, paresthesia. Any questions? No. So, other causes of B12 deficiency. Well, we go back to her husband. He had reflux esophagitis. Okay. Now he's been on acid suppression because of his reflux esophagitis. Acid suppression, obviously, you've got to suppress it if it's burning his esophagus, otherwise you're going to get esophageal cancer. But by suppressing the acid, you get something called achalasia, where you don't have enough hydrochloric acid. Now, hydrochloric acid is the second part of digestion. The first part of digestion, saliva. Second part, stomach acid. Third part, small bowel, or duodenum, pancreatic enzymes. That's the digestive system right there. Now, he's relatively acholetic. Now in US, I don't know how they manage this sort of statistics, but 6% of people in the US are vitamin B12 deficient. When they get to 60, when you start falling off of your acid in your stomach, you become acholetic. 20% of Americans have achalasia and can't absorb B12, so the B12 level is low. And B12 is one of the most important vitamins. Out of the 8 B vitamins, it is the most important. Another thing that upsets sorry. The other problem with it's not just achalasia, it's also drugs can interfere with absorption of B12. So there's metformin does. Sorry? Interfere with B12. I don't know that one. Is it? I don't know. No, I'm talking about what this becomes really complicated now. So we're talking about, if you want to talk about B12, the B12 is in two basically active and inactive states. An inactive state is cytocobalamin, and a reactive state, which can be absorbed and used, is hydroxycobalamin. Okay, so you have an inactive proportion and an active proportion, and if you can't, we're still unsure about the levels of B12. Like, 20 years ago, it was between 50 and 250 was accepted as normal range. Now it's gone up to over 800. But there's evidence now in cerebral function that you have to have at least a level of 550 B12 units to protect the brain. But if you've got a combined hydroxycobalamin and cytocobalamin, if you've got that combination, then then what proportion of that is free that's available to the body? Well, we don't know, and you can't get a free B12 level over here in this country, which is a shame, because this is all fairly new, and we need to know this. Any questions on that, by the way? No? Well, everything that's not vegetarian. So all vegetarians need B12. Seriously. So it's any meat, cheese, milk, anything. Sausages. Sorry, iron deficiency.
Can people wait for a mic, because we need to capture this questions for the
Yeah, I know. That's later. So, can I answer that question later? Okay. Otherwise, I'll get stuck on this. All right. Okay, here's another one for you. This is another one that I saw. This is another one that I spoke to on the phone. So this is Kevin. He's 67 years old. Progressive weight loss from 68 to 51 kilos in 6 years, and he had anhedonia, miserable as sin. And he had symptoms of prostatomegaly, past history of dyslipidemia, hypertension, etc., etc. Smokes, I love this, 15 to 20 cigarettes a day for 57 years. Since he was 20, non-stop. And I said, "He's still smoking?" He said, "Yeah, but I don't inhale." Oh, well, that'll work. Okay, so here we go. Anybody want to hazard a guess on what's going on here? Well, first of all, let's go back to the story. Progressive weight loss. First thing you think of, progressive weight loss. Yeah, but why isn't this cancer? Too long. Unless you had a low-grade lymphoma or something. Too long. 6 years. So, he's got, you can see he's got monocytosis. These are white cell counts, are all elevated. Do you know what that means? Infection, basically. You can also get that with cancer, by the way. Red blood cell count. Hemoglobin, 12.9. So he's nutritionally deficient. See that? 12.9. Where is it? Hemoglobin. See, it should be 14 to 18. And if you look at his cells, mean cell volume, these are corpuscular hemoglobin. Where is it? Looking along the line. See it properly. 28.3. See, that's lower limit of normal. The volume of the red cells is okay, so he hasn't got a vitamin deficiency. Okay, but it looks like he's nutritionally deprived here, and that would go, of course, with what he's saying. He just doesn't eat. He drinks beer, but he smokes, but he doesn't do much else. And the other thing that's the clue here is the ESR, C66, which means infection. But because he had prostatic symptoms, I did a stool test. I thought he might have got low-grade gut cancer. So I did a stool occult blood on him, and that was that was positive. But he had a pile, so that doesn't count. So it doesn't look like he's bleeding from his gut. Over here, there's the nutritional deficiency there. See, he's low in protein. And alkaline phosphatase. Don't worry about that. That's Gilbert's syndrome. We see this as an isolated abnormal liver function test, alkaline phosphatase. That's just a genetic inherited condition. All right, so now we go on to screening, which I don't like the screening that happens over here at all. So this is some of you have seen this before, but this is a patient who in 2019, there's his weight, blood pressure was a bit high, hemoglobin was high, well 16.5 was it? I can't read that. His MCV was 103 mean corpuscular volume, so he had big red cells. Was he vitamin B12 deficient? We'll see. Anyway, otherwise it's okay. And you see the urine test, see here? How do we know he hasn't got prostatic cancer? How do you know? No. See, look, when I do a dip test, a urine dip test, what it cost? $1 for doing this. There is no blood in his urine. And the most common cause of microscopic hematuria in a man is prostate cancer. and if you see the blood in your urine, then the most common cause of that is transitional cell carcinoma of the bladder. But so we've eliminated that without doing a whole heap of abnormal, unusual, unnecessary tests. See, his cholesterol, his LDLs were high, creatinine, kidneys were okay, protein stuff. So he was 18 months later. He was feeling unwell, so he went back to the same private hospital. This was in Buriram for a further screen, which was this. Now, the doctor said there was nothing wrong with him, and he was encouraged by that. He thought, oh, that's good. 6 weeks later, it wasn't any better, so he gave me a ring. Anyway, you can see here his blood pressure's well, we'll start from the top. He's lost 10 kilos. Okay? What's that? 12-15% of his body weight. His hemoglobin, 16 to 14.4. And if you look, where are we? MCV, it's fallen from 103 to 96, is that right? Yeah. And his mean corpuscular hemoglobin had dropped 10%. And this is, in response to you, this is what happens. Somebody who's bleeding. So this chap had lost weight, he was feeling unwell, and he was getting reflux. And somebody at the age of 60 plus, that's cancer until proven otherwise. And you're right there. But we can see the difference just by looking at the parameters of the blood test. Okay, so this chap was given a clean bill of health. Came to see me. 3 quick questions, and I made the diagnosis. He had his esophageal cancer cut out in Surin, and I sent him back to the UK for his chemotherapy because he couldn't afford it over here. He died 6 months later. Didn't have a hope really because of this, and it wasn't treated properly. Very sad. Okay. So, this is the health screen. This is Phaya Thai, and Phaya Thai, by the way, is a good hospital for screening. But these are just some results from a patient. So you can see his cholesterol was high, triglycerides were high, HDL, LDL, low density lipoproteins were high. But these are the parameters, and most of them are wrong. Most of them are totally wrong, according to Western medicine. This triglycerides, less than it's not 150. You need to get there less than 100. If you get less than 100, and he's nearly there. Look, if you get less than 100, then fats have very little effect on you. His uric acid was okay. Uric acid. Any idea why we do uric acid with the cholesterol levels? Yeah, but why? I mean, I know it's painful, but is there another reason? Any idea? No? No? Oh, it can cause it. Yeah, you're right. I don't know who said that, but it causes that. But what it does is it increases the damage or the potential damage from your low-density lipoproteins. So you've got to get your level down less than 7. And if you've got gout plus hyperlipidemia, then it's snookered. Get the gout level down. Colchicine does that. Creatinine. So here we go. What's here? So this is a liver function test. That's okay. This was a limited. I think this only cost him 4,000. So here's the other. So we know he's not got prostate. Yes. See, this is his urine. This is urine up here. I'll help you guys over here so you can see. Okay, I can see this one better as well. So you can see the ketones, bilirubin, nitrate, there's no leukocytes, no red cells. So, on that, do you need a PSA level? without any, and he's got no symptoms. No. So the next sheet. So you do a standard chest X-ray. He didn't have an EKG. Standard chest X-rays. He didn't have any lung symptoms, lung problems. But you get this chest X-ray in. Why do you need it? I mean, you know, what do you expect to find? You're not coughing, you've got no symptoms. By the time your lung cancer you pick up on X-ray, it's probably a bit late. And same with this. So there's your PSA. You didn't need that doing, not that he had it done. But these are all the tumour markers. See them all? AFP, CEA, CA15, 12.5, CA19.9, CA15.3. They're all tumour markers, and they do this all the time. But you have to have a highly established tumour before this becomes positive. And we actually use these results to monitor whether the chemotherapy treatment that you're giving to reduce the cancer load is working or not, because these figures drop. But you cannot identify, well, by the time you identify using these parameters, it's too late because the tumour's really advanced. And yet they do them all the time. Every time you go for one of these screens, you get this done. Waste of money, in my view. You'll see why later. All right. So here we go. The ultrasound, the whole of the abdomen. Why do you ultrasound the whole of the abdomen on everybody who's having these screens? I mean, it's, you know, an ultrasound isn't going to pick up a stomach cancer. Might show some fatty liver, but it's not necessarily going to show portal hypertension or anything like that. See, the urinary bladder was okay. Prostate gland is not enlarged. No ascites. So what? But you can tell those things, whether they've got ascites or not, or whether they've got prostatomegaly or something. You can do a physical examination. It's easy. You don't have to pay all this money. You get the gist of what I'm saying. A lot of these tests are unnecessary, and yet the guys go every year and pay. Well, this one was 4. If you have the full screen, it's 10 or 12, even more. So this is screening in Australia. So talk to your doctor. So by the time you're 60, you should know what's wrong with you. Do you know what I mean? You should see a doctor, and you should be aware of your blood pressure. You should be aware of your lipid profile. You should be aware of your diabetic risk. That's what good doctors do. They include the family history, and they talk to you about your symptoms if you've got any, and they do a health screen, but you don't need one done every year. So this is a recommendation in Australia. So talk to your doctor. So every year, flu vaccine, dental checkup, vision, hearing. Every 2 years, heart disease risk assessment. Okay, blood pressure check for bowel cancer and mammograms. Now, check for bowel cancer. The incidence of bowel cancer internationally is 1 in 25. If you have a first-degree relative with bowel cancer, a parent, a brother, cousin, the chance is increased 3-fold, so it becomes 1 in 8 instead of 1 in 25. So through the family history, through taking a good history, you can look at the risk of the incidence of bowel cancer in that person. It's 3 times more than normal. So of course you'd screen them every 2 years. There, but if not, 5 years is 5 years is okay. And then fecal occult blood, nice and cheap. You don't need a colonoscopy. Okay, diabetics risk assessment as you get older. Eye tests every 5 years, cholesterol and lipid test, because you should already know your cholesterol, and it should be treated by the time you're 60. Do you know what I mean? All right, and obviously in Australia, skin cancer checks because it's got the highest malignant melanoma rate in the world. Depression risk assessment. Why is this important? Because people, when they get older, especially if they lose a spouse, or perhaps sometimes they're happy because they've lost a spouse, but most of them are you're reading my mind. But it's true, you know, people get depressed and sad. They're coming to the end of their working life. The children are left home. The wife's not happy or she's sick. So, depression does occur. And of course, full assessment. This is really important over 65. Now, the government in Australia allows, at the age of 75, to have a full assessment. Now, you look at this assessment. So it's information collecting, patient history, performing examination, etc. Making an overall assessment of the patient. How well are they? Are they stable? Have they got peripheral neuropathy? Recommending appropriate interventions. These tests, by the way, in Australia are done by their regular GP, not by independent doctors. Offering the patient a written report about their health and covering their health assessment. Now, specific components: blood pressure, obviously, review medication, assessment of continence, that's really important, 75 plus, assessment of immunization status, assessment of physical function, an assessment of patient's psychological function, cognitive and mood, and need for community services. Now, how much of that is in blood tests? How much of that can you get from chest x-rays and ultrasounds of the abdomen? Nothing. But this is what's necessary for people like Big Ron, who fell in the street. This is what we should be looking at, whether he's unstable or not, which he was, and now is. Do you understand what I'm trying to say? So these health assessments that you have, and you think they're good, and they're very common over here, are not recommended in the West. I mean, they might be in America, but they're not in Australia, are they? All right. I think we're at the end now. Oh, you'll love this. So, cholesterol. Is that the cause of coronary artery disease? Yeah, yes, no. No. Hands for no. Hands for no. Brilliant. Good. The message is getting through. So what causes hardening of the arteries? Oh, before I go there, is there a difference between coronary artery disease and peripheral artery disease? Brain. Are you a nurse? Doctor? What's the difference? No. Oh, that's brilliant. Yeah. Well, no. Peripheral vascular disease is also legs and arms. Is there a difference? Is there a difference between? Does anybody know that there's a difference? Well, there is a difference. Heart disease, and peripheral disease. Yeah, but it's still blockage of arteries. No. Well, I mean, yes, in part, but that's not the reason. This is the reason. Vasa vasorum. So vessels of vessels. So all our blood vessels have little blood vessels in them which supply this is the aorta. There's the blood running through, but the blood as it rushes through can't get through this. It's not even a semi-permeable membrane. It's really a tough muscle sheath. So you have these vasa vasorum, small vessels that feed the main blood vessels. In the heart, it's different. These are the blood vessels. This is at 20 days intrauterine life. 21, it's joining. 22 days. This is 23. Oh, lost it. Anyway, so what happens is that the arteries fold back on themselves to produce the heart. Yeah? But when you've got that, what happens to the vasa vasorum? Well, the vasa vasorum becomes the coronary arteries. That's the difference. So that's why you're more prone to get coronary artery disease than you are to get peripheral vascular disease, because the coronary arteries are altered vasa vasorum. So it's do you understand what I'm saying? So it's it becomes a big artery which feeds the heart. But it's, left and right, basically. And that's it. Where in the vasa vasorum, you've got stacks of them. running along the aorta and everywhere. So, so what causes hardening of the arteries? It doesn't matter where it is. It's oxidative stress. Yeah. So what happens with oxidative stress is the endothelium lining. With endothelium is inside, endothelium is lining. So endothelium of the artery gets damaged. Okay, so you get a hole in the endothelium. Now that's not healthy. So what happens is these foam cells, these things here, these are all foam cells. They're called foam cells because they look like foam cells under a microscope. But they're actually lipid-laden macrophages, white cells, that are full of low-density four low-density lipoproteins, depending on your diet, is contained within these cells. Now these foam cells go in to plug up the hole, but in doing that, the low-density lipoproteins contained within them is inflammatory, and it causes inflammation in the artery wall, and that inflammation needs to be stopped, and it can't progress. So the body protects itself against that by laying down the strongest tissue it's got, which is calcium, which is where you get calcification from in your arteries. So the primary cause of coronary artery and peripheral vascular disease is oxygen stress. Okay? And this is a secondary phenomenon. So the LDLs packed in there cause all the cause the problems, but it's a secondary phenomenon. So if you don't have any oxidative stress, you don't need these. All right. Any questions about any of that? Sorry, who am I talking to? Oh,
So
yeah.
Yeah, what is the?
Yeah, well, they're called free radicals. Too much oxygen. They just need to be combined with something. So you need, flavonoids, for example, in chocolate are really good. They're antioxidants. Any form of antioxidant you can get, is good. I can. Not today. I'd have to type it all out because they're lengthy. Any other questions? Yeah.
In America, there was some research done, and a Nobel Prize winner for NO with the amino acid L-centroline to create this. Can you talk about that?
No. Antioxidants. Is that an
amino acids, L-centroline.
Yeah.
Creating NO in the blood to.
Nitrous oxide.
Yeah. Can you?
No. You
don't know. Thank you.
No. I'm not a biochemist. I'm a pain management man. So. Sorry, I can't. I've been retired now for 7 years, so I don't keep. I used to read heaps, but I don't do that so much now. So do you want to do, I sit down and you can ask me questions if you like. Not hard ones like Americans. Not make them nice and easy.
All right. Firstly, thank the doctor for his talk so far. And he's originally he's just going to do a Q&A with any questions people had. I said, we'll throw together something short to talk about beforehand. So,
have I gone over time?
No, it's great. It's great. We always learn something from the good doctor. So just general Q&A about the talk or anything.
Where is the
just a written report, and they can't deliver it because the patient doesn't have a doctor. They don't have any evidence that it was a test without any test. Well, that's how we finally got it. No, it'll come cost in your practice. You'll have to spend money on it. You'll have to spend money on it.
So what he's saying is that they won't win.
They will have to answer, they will have to respond to the credit card company. They will have to make the because the point is commission pays for this, even if they don't pay for it. Okay, the point is to make them know this isn't on. Even if I don't win, the point of this the doctor responding to the credit card company to not deliver the money. Try to get things fixed, even if you don't necessarily need you personally to a doctor, you have to call a credit card company and then the cost is going. Those credit card companies will immediately reverse the charge. That's how it works. The hospital then has to prove the charge is valid. So the hospital will have to respond if they want to keep their money.
Well, all I can say is I wish you well. Good luck. Please let us know how it goes. We're on your side. Stay tuned.
Sure. Yeah, I know. We're not saying that at all. There's two different approaches. Why are we arguing that? There's two different approaches. You can go personally to be unsuccessful, or you can go through.
I've advised companies like the they have to documentation to credit card companies.
But that's not you. You're the credit card company on your behalf. It's not you. He's saying you've got no chance. And we all agree with that. That the big company will confront the big company. But you can't do that. Don't waste your time. That man who died 6 months after the story, he ends up back to the UK. You might know this story. I spoke to him about before he died. And I said, look, this is medical negligence. You have to do something about it. I don't want anybody else to suffer what I suffer. Cost of medical negligence. So I went right up to Bangkok. And the doctor that missed the diagnosis was very around. And also taken endoscopy. He got tornado cold. Took out maybe but the doctor who missed the diagnosis made that false presentation. He got off the street, even though his doctor was that dad seen it nothing, no what we do is the best. You guys need to know when you have blood pressure Big lot of fun. Yeah, well, it's really good question. And in Australia, we do it every 5 years as the Olympic cycle. And it's 3 independent councils. And because of it, then you get
Where do you get the students to go
So he had a that's why I had a positive signal for blood, so it's not that accurate. The students going out very good. And yes, he's right. Just in response to that, in the UK, they have a triage system in clinics, and the triage system, first part isn't necessarily even a nurse. If the person on the desk thinks it's important, then they put you through to a triage nurse. Now you're talking about history. Well, 82% of diagnoses can be made on history alone, but you've got to take the full history. You can't just say, oh, well, what's going on? You need to take a full history. You need to look at the patient as a new person. Everybody is different. And there isn't one pro forma which will give you the results for everybody's pathology. because everybody is different. And that's the beauty about medicine. That's the beauty about being alive. That's the beauty about being human. Makes medicine a bit tough, but you can get there. But these nurses aren't trained to do that. That's the problem.
Yes, I guess I've been fairly lucky here. I've attended 2 clinics over the years and been to 2 hospitals. I don't have any complaints. There's a lot of talk about misdiagnosis this morning. Do you know the average of misdiagnosis in Australia? On average?
Don't know, no. Got no idea.
Take a guess. Uh, 148,000 cases on average every year.
Of what?
Misdiagnosis in Australia. So I'm just bringing it up because I think a lot of people like to dump on Thai medicine.
No, well,
You know,
Just a quick question was raised for me to pass on is what causes the oxidative stress that you emphasised as being so important?
oh, everything. Alcohol, smoking, being ill, not being fit, not accepting your age. I mean, everything. Anything that stresses you out will can
Booking
cause
speakers for the Expat Club? That's
Sorry?
all?
Speaking for the Expat Club.
What about eating the wrong foods? Is that what about
Eating the wrong foods, yeah.
eating the wrong foods?
Yeah.
Uh,
And sorry, go on.
Well, while I think of it, who here is from Australia? Okay. Who here, when they were growing up, was told getting suntan is good for you and the sun's so great for you? Got suntans.
Well,
Get regular skin checks for cancer, okay? I've said this before at the club, especially if you grew up in a high sun environment and you're white. I go to Pattaya International Hospital, Dr. Wallapoint, she's very good. My friend who gets tests in Australia said she's more thorough than the Australian doctors in checking your skin. Picked up a melanoma in my back, had it cut out, all good. I go at least once a year. So we had a South African here, he obviously wasn't listening to me, didn't get regular skin checks, got skin cancer, went back to South Africa and died from skin cancer. Okay, so please, there are certain checks. Talking about history of the person, if they have a history, like when I was young and I stopped getting suntans, one of my friends would abuse me, oh, you don't look healthy, get a suntan, get a sun into you and stuff. So, yeah.
Oh, they'd spray you in oil just to make you browner. on
Yeah,
the
and
beach.
you do things would happen that would be regarded as cruel. You send kids off to, would walk for an hour to school, an hour back, and no hat and stuff like that. It was craziness, right? Now, we have one more question.
Thank you, Doc. I just wanted to get some clarification. I think I heard you say that you can get prostate cancer checked through your urine.
Mm.
Is it enough for that?
Well,
a urine test?
it's not just a dipstick test to see if there's red blood cells there. I mean, you know, prostate symptoms mean something, okay? And if you've got no prostate symptoms, frequency at night, particularly getting up at night, hesitancy when you go to the toilet during the day, terminal dribble, soiling your underwear, they're all significant symptoms, and they should be taken into consideration. And then if you do a urine test and there's blood in there, then you go and do a PSA. That's the way I work in any case. And people don't like rectal examinations, and I understand why, unless you're experienced at it, and I've done a lot of them. It's uncomfortable. And if the doctor doesn't know what they're doing and what they're feeling, and then if they're a female practitioner who's hardly done one, to do one every year, they don't know what the sulcus feels like, and they don't know how big a gland is. So it's horses for courses, you know. It's like everything in medicine. Yes, it's adequate because you take the symptoms from the patient, you take into consideration, you take his family history into consideration. So age first, so if he's 50, then that's really serious. And another risk factor for prostate cancer or serious prostate cancer, is first-degree relative. So if he's had a brother or a father had cancer in when they were 50, prostate cancer or 55, then that chap should be screened at 40. And the other thing is that even if they've got a family history of breast cancer, the BRCA gene can affect prostate cancer. So there's lots of causes of prostate cancer which you don't think about unless you know about it. But that's our job, not your job. Do you know what I mean? But when you go to a physician, if he doesn't do his job properly, things will be missed. That's what I'm trying to say. Get a physician you can trust.
Final question over here, Doctor.
About 2 months ago, you gave a presentation about this poor guy who got all kinds of bad things happen to him in Australia. What was the total number of things that happened to him that was a screw-up? That guy was you.
You don't want me to go through it again, do you?
No, it's just the total number. Just the total number.
Well, I've had 5 hip
He can't count that high. Okay.
No, I've had 5 hip replacements. I've had spinal fusion. Okay, I've had atrial ablation 3 times, and then the 3rd time I woke up in the middle of the procedure. But this is in a cath lab, so I don't know where the anaesthetist was. He was probably off having a coffee or something. But the chap who was doing the ablation, the cardiologist, I'm there lying like this. I think this feels very strange. But he finished, so it was all done. What else have I had done? I think that's about it. The major ones. So I've got 6 pedicle screws, 2 Harrington rods, 6 bone grafts in my lumbar spine. And I showed you my neck, which, you know, if I have a car accident, for example, I'm snookered, because if I get an acceleration, deceleration type injury, it could affect my breathing capacity. Because remember, yeah, something like that.
All right.
But I'm 68, so at least I'm alive.
Nothing as painful as doing a Q&A at Pattaya City Expats Club. A huge round of applause for the good doctor. We're so privileged to have him come here.
And in final answer to your question, I came over here because I was expected to die. I had a coronary calcium score in the top 90th centile. So that means if you take all the people of my age and ethnicity into consideration, all the drug addicts, all the diabetics and all that stuff, 90% of them would have less coronary calcium than I had. Well, it depends if you go on the percentage or the androgen one. 200 and something, but it comes out about 1,000 because they're doing percentages over here now as opposed to the old style. But basically, from the number you get a percentage rating, and that gives you your risk factor. Now the risk factor for me was I had 5 years. I was supposed to have a catastrophic heart event. So I came over here. I left my medical chair. I didn't want to die in that. I retired early. I sold everything, 2 houses, medical practice. Within 3 months, came over here, and I started working. Now, we're talking about oxidative stress. Hard work is not oxidative stress. Being fat is oxidative stress. Being unhealthy, eating wrong foods, causes oxidative stress. Look at me now. I lost 10% of my body weight. I built myself up. I didn't do a lot of weights, but I did a lot of manual work. I got 2 rides and built a chicken and turkey runs and things. So if you treat your body with respect, it will respect you. And the body is always trying to heal itself. Always trying to heal itself. And if you stay healthy and well, then or you make yourself healthy and well, then you will stay healthy and well. And it, by the way, it was what I went through was really awful. It was awful. I was on morphine and everything. God, when I look back. Okay.
Well, I can't speak for everybody. I think I can. I can speak for everybody here in saying, we're glad you're still alive, mate. And thank you for sharing what you know. All right. Well, ironically, now, you've all